Doctor, I'm a 55-year-old male, and I'm really concerned about my health. Over the past few days, my shortness of breath has been getting progressively worse. It's gotten to the point where I struggle to breathe even when I climb just a single flight of stairs. The dyspnea is really distressing. Along with that, I've been coughing severely and producing thick mucus from my airways. It feels like my lungs are really struggling. I want to share my medical history with you. I've been diagnosed with chronic obstructive pulmonary disease, COPD, and in the past it got so bad that I had to be intubated due to respiratory failure. I also have a long history of smoking, about 12 pack years. I know it's not helping my condition.
Doctor, I prepared the review of physical examination and data. Physical examination findings include grossly asymmetric rhonchi on lung auscultation, symmetric bilateral expiratory wheezing, symmetric bilateral decreased breath sounds, and no inspiratory rales. The patient is observed using accessory respiratory muscles. Vital signs show blood pressure of 115/70 millimeters of mercury, heart rate of 70 per minute, temperature of 99.4 degrees Fahrenheit, respiratory rate of 15 per minute, BMI of 19 kilograms per square meter, and oxygen arterial saturation of 90% on room air. Laboratory data reveals a blood white cell count of 5,724 per microliter. Pleural effusion is not present. Arterial blood gas analysis shows a carbon dioxide level of 58.2 millimeters of mercury. Doctor, what do you think is the diagnosis?
Based on the information provided by the patient, there are several key factors that strongly suggest a COPD exacerbation as the most likely diagnosis. Let's break down the reasons. History of COPD. The patient has a known history of chronic obstructive pulmonary disease, COPD, which is a chronic condition characterized by airflow limitation. COPD is often associated with recurrent exacerbations, during which symptoms worsen significantly. Progressive dyspnea. The patient's dyspnea has been progressively worsening over the last few days. This pattern aligns with the typical course of a COPD exacerbation, where shortness of breath becomes more pronounced. Dyspnea during exertion. The patient experiences dyspnea specifically when climbing stairs, indicating that physical exertion triggers their respiratory distress. This exertional dyspnea is a common feature of COPD exacerbations. Increased mucus production and severe cough. The patient reports thick airways mucus production and a severe cough. These symptoms are consistent with exacerbations of COPD, which can lead to increased mucus production and airway inflammation. History of smoking. The patient has a significant smoking history of 12 pack years. Smoking is the leading cause of COPD, and it exacerbates the underlying disease process, making the occurrence of exacerbations more likely. Physical examination findings. The physical examination reveals auscultation findings indicative of airway obstruction, including grossly asymmetric rhonchi, symmetric bilateral wheezing, and decreased breath sounds. These findings suggest the presence of bronchospasm and airflow limitation, which are characteristic of COPD exacerbations. Past history of intubation due to respiratory failure. The patient has a prior episode of acute respiratory failure requiring intubation, which further supports the diagnosis of COPD exacerbation. Respiratory failure is a severe manifestation of exacerbations and underscores the significance of the patient's current symptoms.